MSK intervention radiology. Fractures, of course. Tendons and joints, I'm not going to talk about so much. MSK radiologists will probably be doing ultrasound of these, offering steroid injections, using a needle without injecting anything at all, using a needle to fish out flecks of calcium from a tendon in calcific tendonitis under ultrasound guidance. And they play a role in the treatment of cancer, but the real cutting edge stuff is the inflammatory conditions like osteoarthritis. So it used to be thought that it was just wear and tear on the joint, erosion of cartilage through overuse, and that there was no real way to repair, to fix this or let the body heal and repair itself. Now we know that's not quite true. There's some biological process of inflammation. It's flare and repair, because it rhymes with wear and tear. And cartilage can repair itself, and it can heal, and it can increase in thickness. The traditional treatments are physiotherapy to strengthen muscles around the joint, non-steroidal anti-inflammatory drugs, and steroids. Surgery, so you can stick a camera in, that's what we mean by arthroscopy. You can remove sort of loose pebbles of cartilage and bone that are rattling around. You can smooth down and remove osteophytes, resurface and trim cartilage that's sticking out. Joint resurfacing is surgery where you're cleaning off the cartilage and putting a bit of metal or plastic on, and then joint replacement is the final step, leaving someone with metal on metal or plastic on metal instead of cartilage. And there's always been this idea of growth factors that you might inject to make the cartilage suddenly start to repair itself. That's not really played out, but people will still try and sell injections of platelet-rich plasma. So just as a theme, when you look at an X-ray, you only think about the bone, but there's actually a lot more tissue going on. There's your muscle, there's your fat pads, your cartilage, and just this graphic I took from a Nature paper really shows all the factors at play for inflammation and healing. And it's mostly the macrophages which are doing all the work and coordinating the regrowth or the inflammation. So how else can you treat this? Well, we don't have any disease-modifying treatments yet. NSAIDs don't slow down osteoarthritis. And there's been a lot of effort to try and repurpose the rheumatoid arthritis drugs, drugs that work on the cytokines and inflammatory mediators. And they don't really help that much in OA, or they help a few patients, but it's very hard to choose exactly who will benefit. But this is an interventional radiology talk, and I'd like to talk to you about embolization of these inflammatory conditions. So embolization means you are injecting something to block off a vessel. So if you have a pulmonary embolus, that's a blood clot which is coming up from your legs into the pulmonary arteries. But you might do a similar procedure to block off an artery to prevent bleeding, to stop blood flowing to a tumor so it shrinks and dies. But in these specific cases, you aren't completely blocking a large artery. You're injecting particles that plug up some, but not all, of the smaller arterioles. And you can do this for other benign disease processes around the body, like you can embolize the stomach to give an effect a bit like a partial gastrectomy for weight loss. The lungs as well, to prevent airway hyperreactivity in asthma or cystic fibrosis. But what I'd like to talk about is genicular artery embolization. So genicular arteries are the four little arteries around the knee. This is an X-ray of someone's knee. They've got a knee replacement. That's the white metal. These two pictures here are subtraction angiograms. So they've subtracted the original X-ray, and you can just see the sort of outline of the metal here. They've put a catheter down into the tube, and down into the genicular artery and injected. And this big blush is not inflammation, it's actually bleeding, because this is a procedure that was invented to deal with bleeding after knee replacements. And that's true for a few other sort of well-established IR treatments like prostate artery embolization. It sort of started as something to help out the surgeons. But you can also treat the inflammation of cartilage and synovium with the same procedure. So this big tree trunk in the middle is the popliteal artery. It's only about 4 millimeters wide. So what you need to do when you're getting your catheter into one of these side branches, these are tiny, maybe a millimeter or less, is really quite a challenge. And this is a nice before and after picture. And if you see many normal ones, this sort of cloud or sort of web of capillaries, that's a bit more than normal. That's overgrowth of the vessels. If you cut this knee open, you'd find that the synovium here was pink and injected. It would look like someone with conjunctivitis. And then after, this is what it normally looks like, just a few large vessels which fill with contrast, and then a few smaller ones which don't. So you're not killing tissue, you're not completely blocking everything with coils or something. You're actually using an antibiotic called imipenem cilastatin. So that's, I think, related to meropenem. And that forms spheres when it sort of comes out of solution. So yes, it's shown, this treatment's shown really great results for pain, for inflammation, for distance you can walk. It doesn't regrow your cartilage. It doesn't affect the menisci. It won't realign your knee if one side is more degenerate than the other. You might get some skin necrosis, but there's no serious complications recorded yet. So this is an excellent treatment for patients too frail to have a knee replacement, too frail for general anesthetic. The long-term results are not yet known just because we've only been doing it for a short amount of time. There are a few more targets, a few different conditions, not osteoarthritis, but which have a similar underlying inflammatory process, and they're all unified by too many blood vessels. So first I'll talk about lateral epicondylitis. So that's tennis elbow, something you get when you overuse your muscles, so too much extension. There's another condition called golfer's elbow, which is too much flexion of the elbow. That's the opposite of tennis elbow, and it's specifically this muscle here, extensor carpi radialis brevis. Most patients improve with time and physio, maybe a brace. It's incredibly rare to need surgery, but what the surgeons do is they make a cut. They chop out some dead or inflamed muscle. They chop out some bone spurs, and then they sew you back up. It's not a tenoplasty operation. It's just removing small slips of muscle. But this is a condition where most people get better with time. The results from embolization, and here you can see an angiogram of a normal person's elbow, and here this extensive overgrowth of capillaries and small vessels, like a tree with more branches. So the treatment of this, yes, it's shown results, but it would be hard to prove its lasting benefits over just simple conservative management. So this is an interesting treatment, a great idea, but maybe not one which will be very commonly offered. Frozen shoulder, on the other hand, is a very painful condition. First, your shoulder starts to hurt and swell up, then it's frozen. Now, that doesn't mean you can't move it. It means no one can move it. So when you examine these patients, it's not that their muscle is in spasm or their rotator cuff is weak or they've torn a tendon. If you take their shoulder and try and move it, it won't move around. And then after that, it starts to thaw and come back to normal function. And that process can take up to 3 years. Just imagine being in a collar and cuff for 3 years. That would, really change your life just a bit more than wearing an elbow brace would, and being told to stay off the tennis court. So the current treatment, it's similar, physio, NSAID, steroids. It's maybe a common theme here. You can put the patient to sleep and just sort of crunch around their shoulder and break up the inflammatory adhesions. That's manipulation under anesthesia. You can stick a camera in and sort of snip around and free up the adhesions. Radiologists can also put a cannula in and blow up the shoulder capsule with fluid. That's hydrodilatation. That's much less invasive and is shown to be a bit more favorable and certainly more cost effective than arthroscopy. This is what it looks like when you've got your camera in. So those pinkish tinge, big vessels here, that's what I've described, the overgrowth of the blood vessels. This would be a normal shoulder on the left. And you can do a similar thing. You can embolize and block off these vessels and reduce the blood flow and treat the inflammation. All of these treatments and a few more, like plantar fasciitis or Achilles tendonitis. A lot of the work being done is in Japan, especially the lab of Dr. Yuji Okuno. It's slowly coming over to the UK and America. I think the knee osteoarthritis will be the biggest, most in demand. And that's because there's so many patients who are incapacitated by their symptoms, but who are just a bit too frail for a knee replacement. So I think IR has really a lot to offer these patients. Now it's our job to expand the evidence base and expand the practice, and also raise the profile so GPs and people who refer are aware of what's on offer. So now we're going to go on to the more classic things, classic presentations, which you might see in your day-to-day job. So this is a hip x-ray. Can everyone see the fracture? Well, yes, you can just say, yes, it's obviously broken, but what are you actually looking at? You might see the sharp cortexes here, these sharp spurs where the cortex is broken. You might see this triangle where everything's more dense than you expect, where the bone is overlapping. There's more bone than normal. And you might see this area where everything's a bit less dense, less x-rays are being stopped. It's more black than you'd expect. And that's where the bone has been sort of pulled apart. This is the lesser trochanter, which has been detached. And then if you follow my mouse as it comes up here, you can very obviously see that bend. This should be a nice curve, and a curve which lines up with the obturator foramen here, called Shenton's line. This is what a normal hip looks like. It's a little more complicated than that, but once you spot a fracture like this, the next thing you might be asked is, what would you choose to fix it? How would you operate on this? Remember, hip fractures don't do very well if you just immobilize them. And that's because of the blood supply of the femoral head. When that's disrupted, you're very likely to have avascular necrosis. And that's when that ring of circumflex arteries is disrupted by an intracapsular or displaced fracture. The capsule is sort of about here. So anything below that, you try to keep the femoral head. You put a metal plate or rod to hold everything together, but keep the bone and cartilage rather than replacing the joint. Anything above that, you say, well, metal on metal is not as good a joint as bone on bone, but it is needed because otherwise the femoral head will die. So that's when you choose the two options here on the right. And then for the lower down non-displaced fractures, you choose things on the left, these three. Cannulated screws, almost minimally invasive. Dynamic hip screws, sometimes you place a second screw here to prevent rotation of the fracture around the single axis. And intramedullary nail, something a bit stronger, something which internalizes the fixation and prevents strain. So this one, the dynamic hip screw, the force on the metalwork is a bit like someone holding a package with their arms far out in front of them. And the IM nail, that's like bringing the package a bit close to you because this sits in the shaft in the medulla of the bone. A few more cases. I want everyone to try to look at this for a moment, think about what they can see. So this is a 70-year-old female, full right hip pain. This is their left hip. They've had some metalwork put in. So you can see this is a shaft that's been hammered into the femur. There's some cement around it. Is this a hemiarthroplasty or a total? Well, this ring around here is actually a metal wire in sort of a plastic cup. And that cup has been cemented in. So they've made a few drill holes here, and then this dense material is bone cement. So this is a total hemiarthroplasty. And then we can look at the right hip where the pain is. We can see these beams here. These are the trabeculae. They sort of follow the line of stress. So there's a compression and an extension loaded beams. Those are normal. So I don't think there's a subtle fracture across the neck. You might see this protuberance and say, is that a sharp bit of cortex where there should be a straight line? And that's actually a ring osteophyte. So like a collar around the femoral head, just some bones both sticking out. But the fracture, and there is one, it's actually here. It's in the acetabulum, the socket of the ball and socket. And unless you look, you're not going to see this. So you need to trace these red lines on the inside of the pelvis, and here the iliopubic line in blue. And if you compare both sides, I'll just take them away for a second. If you compare both sides, you can see these are clearly very different. So this patient would certainly have a CT. You'd want to see if the two load-bearing columns of the acetabulum are affected or not. If they are, they'd need surgery. If not, they'd be they'd have traction for a bit, then they'd be discharged non-weight bearing for that to heal up. If you saw this x-ray and said, well, there's no neck of femur fracture, everything must be fine, you'd be missing a trick, because there is a lot more to look at on the pelvis radiograph. Okay, next quick case, 90-year-old, unable to mobilize, query pain at right knee. And this is instantly a very normal knee x-ray from the side, from the front. The trick on the horizontal beam laterals is to look for an effusion, or especially an effusion with a layer of fat floating above the blood. That fat can only come from the marrow. That indicates a fracture. Of course, anyone can have a knee effusion if they have osteoarthritis, but that layer, which isn't present, it's very reassuring. And if you trace all the way around the cortices, you'll see that this is very normal. This is probably not an x-ray of a 90-year-old. This is someone much younger I took from Radiopedia, but reassuringly normal. And in fact, this x-ray might go with this patient. And this is just a reminder to always think a bit further than just one joint. That's a very holistic way to do orthopedics, isn't it? But as you present a patient in an OSCE examination, you always finish by saying, next I would examine the joint above and the joint below. If you're having a similar thought in your clinical practice, it might just be worth x-raying the joint above or below, because you can get a lot of referred pain from these hip fractures down to the knee. Okay, next case, something a bit different. 17-year-old male, query left neck of femur fracture. Well, what's the history here? Was there some high energy trauma? Not exactly. Pain after playing football. Okay, they did some dodgy tackles. They finished the match and managed to walk halfway home. Okay, so that's not someone who's fractured their long bone. They would probably not finish the match. They'd probably be in instant agony and unwilling to weight bear. That's not as true in the elderly, or when muscle spasm and an impacted neck of femur fracture can allow some weight bearing, but that would be unusual in a 17-year-old. So we're looking about the left side. We're looking now at the acetabular roof. That's normal. The front and back of the cup, which we're seeing sort of diagonally side on, those lines are normal. This is Shenton's line, and if there was a neck of femur fracture, you'd expect this to look sort of broken. And the ilioischial and iliopubic lines, those are fine. If there was any sort of bump or break in them, you'd think about the acetabular fractures. Okay, this is the abnormality. Well done if you spotted it. What this relates to is an avulsion of a chunk of bone, and that's by the quads tendons, or specifically, not all the quads. This one is from Sartorius, but the quads attached to the anterior inferior iliac spine. This is the ACIS. This is the Sartorius attachment. This 17-year-old has been doing a lot of kicking and a lot of recruitment of his muscles. He's managed to tear off a chunk of his very flexible, springy bone by the strong muscles and tendons. This patient could be managed conservatively. They could have some painkillers. They'd weight bear, or maybe do partial weight bearing, maybe stay off the football pitch for a few weeks, but this would all heal up back to normal. And it's just a reminder that, of course, if you were concerned about a tendon injury, you might think about an ultrasound or MRI. It's rare to see this on X-ray, except in the young when they've got such strong tendons and flexible, malleable bones. Okay, and these are the sites of the tendon attachments where you can also see similar things, not just here at ACIS. This is just a reminder of those lines you need to check when you're not just looking at the neck of femur. You then take a moment to focus your attention around the rest of the pelvis. This is, the areas to check. So green, obvious, your neck of femur. Most surgeons will like to check the other side to compare it, to think about planning treatment, to make the fractured one look like the old one. Yellow is just being diligent and forcing yourself to move your eyes around. Look at the pelvic ring in major trauma. Look at the pubic rami. Look at the lumbar spine. It's a bit like when you take a stethoscope and you listen to someone's chest. You don't stop just when you've listened to the right lung apex. Even if you find an abnormality, you just routinely go on and do the whole exam and listen in all those 6 places. Orange, an advanced area, difficult to spot fractures around the acetabulum. If you do orthopedics, you might do all your training and then a special acetabular fellowship before you're even allowed to think about this, and you'd be working in a specialist center. And then red is the danger zone. Lesions just at the very bottom of the radiograph. Easy to miss that just due to your attention, which is focused in the center. And lesions below, off the sort of edge of the screen, which you can't see, but you do need to think about. Okay. Here I'm showing you a patient who's had their femoral head cut out. This is called a girdle stone procedure. This used to be done for TB. Now that's very rare to affect your bone so severely. Now you might see this if someone's had a lot of surgeries and there's none have really worked. Recurrent fractures, recurrent problems with metalwork. But I just put this in so you can see the two lines. Here's a blown up version of the sort of front margin and the back margin of that cup of the ball and socket joint. And normally when the femoral head's there, you're trying to look through the femoral head to look at these lines, to look for an acetabular fracture. This is just what it looks like without the bone in the way. Thinking again about those lesions a little lower down off the normal pelvis x-ray. This is a lytic lesion with sort of half a fracture running through. It's not come out the other side. This will be very painful, of course. The point is, if you're planning a surgery, you want to think a few steps ahead. So if your patient has had pain for a few weeks and then their bone has suddenly snapped, maybe with a light bit of effort like standing up from a chair. If they're very old, if there's a history of previous cancer, this is when you want to stop and think, what am I going to find during the operation? What's the rest of the femur going to be like? So there's two reasons for this. The first is if you find out there's cancer or infection in the bone halfway through, say you're hammering in a nail and you are accidentally spreading cancer cells down through the cavity to the rest of the femur. That's not what you want to do. In that case, you want to identify the cancer before, you want to take a biopsy, you want to do a planned excision where you cut out the bone rather than put in metal inside, because the bone around that is going to get very weak and the metalwork is going to cut out and lever itself out of the bone. And it's also not a curative step. You're just putting some fixation in. And the second reason is you want to know where the tip of your metal construct is going to end. If you thought, if this was a benign lesion, maybe an aneurysmal bone cyst, which it doesn't exactly look like, but just imagine, and you put a nail, an iron nail through this, and that went down to the distal femur and ended here on the radiograph on the left. If you did that, that would be the spot of maximum force on the bone where it's at its weakest. All that would happen is the tip of the iron nail would lever out and you'd have a fracture. So in biomechanics, there's the idea of a stress riser, which is that structures tend to break where, not just when they're weakest, but when their strength changes, when a bone goes from strong to weak, when it goes from thick to thin. So that's why you get a lot of fractures of the femoral neck between the strong trochanters and the strong femoral head. It's rare to get a fracture sort of halfway through the femoral head. It's possible, but it's rare. Elsewhere in the body, this is why when you have a hyperflexion injury, you get a lot of fractures of L1 or T12, where there's that transition from the thoracic and lumbar vertebrae, or at C7 and C6. It's why the collarbone breaks normally occur in the sort of 2/3 along between the junction of the middle third and the distal third. The bone there goes from round in cross-section to flat in cross-section. And if you see enough fractures, you realize they really do occur in very similar ways, except, of course, where the bone is changed by these lesions which make them weak, or where you change it by putting the metalwork in and you create a new stress riser. Okay? If you were treating a benign lesion, or if you were not treating with curative intent, if you were just stabilizing this fracture before it completed, you really do need to know what's at the bottom of the femur. So just a few notes on bone cancer. Metastases are much more common than primary bone cancer. Lytic lesions are more common than sclerotic. Lytic is where you have less calcium, less density to your bone. These look blacker on x-rays. It's, you think, what's the bone being replaced with? Well, it's soft tissue and cancer cells. It's not air, it's not water or anything. Lytic lesions are common with bowel cancer, lung cancer, renal, Sclerotic is classically prostate and sometimes breast cancer. If you see diffuse sclerotic mets in maybe an exam question and prostate cancer is one of the choices, that's your best bet. Radiotherapy turns lytic lesions into sclerotic, which is nice because it kills cancer cells and it makes fracture less likely. Lytic lesions are the most likely to fracture. And there's a whole list of other things that can look like this. You can tell them apart with MRI. Your patient's history might help you there if they've had old x-rays where you still see the lesion. But I just wanted to bring up bone cancer as it's sort of the most concerning, or the time where it's most important to get your treatment right. Like in that x-ray with that sort of half fracture going through the lytic lesion, sometimes you do prophylactic fixation and you'd want to stop and think, is it a lytic large lesion in a weight-bearing bone? Or is it a smaller sclerotic, or they've used the term blastic here. Blastic is building bone, which is what your osteoblasts do. Is there more bone than normal, where that's less likely to fracture? And then based on that, you decide if you want to offer a prophylactic nail. If you get everything right and spot a lesion before you dive in and do an unplanned surgery, you can do an image-guided biopsy. In sarcoma surgery, you'd want to plan to excise a lot of soft tissue, a lot of muscles, because there's a lot of tumor growth you might see on MRI. That's soft tissue, not bone. You won't see on X-ray, but that's what the surgeons plan to do. And your biopsy tract, which the radiologists will do before the procedure, after discussing and planning everything with the surgeon, you want to excise the tract, and you don't want to sort of drill through the medulla and seed tumor all the way through the bone. You want to come in through the cortex, take a sample, and then cut out that area of soft tissue. Okay. So on the right, this image, this is a megaprosthesis. They've cut out most of the femur, and then this is distal. This is joining into normal bone. And the hope here is for curative intent. I think this image I've taken from a paper where I don't think it was cancer or infection. I think this was just someone who'd had multiple fractures and multiple prostheses. And then at the end, they said, let's just do a hip replacement and join that into a knee replacement and make everything nice and strong. And if you have a hip replacement and a knee replacement and you don't do this megaprosthesis, in the middle, that bone between the two bits of metal, that's where you're very likely to have prosthetic fractures. And then you're in this sort of never-ending nightmare of tacking on plates to the side and wrapping cables around, all because the stress is concentrated in that region where strong metal yields to the comparatively weaker bone. So just to summarize all of that, how do interventional radiologists support bone cancer surgery? Well, they help with diagnosis, they help with image-guided biopsy. We do a lot of MRIs now and plan surgery. You plan to excise the biopsy tract, and you plan so you know what you're dealing with, so you're not discovering this halfway through a routine fracture fixation, that the bone is much more soft than normal, or that the distal femur is missing. And then there's a few more classic IR techniques, embolization and ablation. So embolization, like earlier, that's not something we do for curative treatment of bone cancer as we do for, liver or kidney cancer. This is something we do as an adjunct before surgery. Metastatic lesions can bleed quite a lot intraoperatively. You can't really compress bone in the same way that you can organ or soft tissue. Open orthopedic surgery in these cases is a nightmare. The classic one for this is renal cell carcinoma, and those tend to be very hypervascular. So on the day or morning of, or the day before a planned resection, the orthopedic surgeons will get the IRs to embolize and block up all the vessels. And that would be not the small particles used earlier, but more substantial blockage of slightly larger vessels to stop that bleeding. And that tissue will be cut out after. It's just to prevent hemorrhage during the surgery. Ablation depends who you ask, really. It's quite rare to do ablation for curative treatment of bone cancer. Absolute best is excision. You tend to ablate benign lesions or very painful metastases, but it's rare to do that. You can inject cement. I know in Europe they do a lot of sacral lesion cement fixation because that's a very hard operation to do. It's dangerous to do open surgery around the sacrum and pelvis, obviously. In this country, we mostly do osteoid osteomas. So these are benign. They're not cancerous. They're not going to destroy your bone. they actually form more bone, and they look incredibly subtle. So here, there's just a sclerotic rim around this central bit of fluid in the cortex of the. This is a tibia of a child, and it's just forming a little more bone. But these small lesions can be incredibly painful, and classically, what you'll see on sort of an MCQ question stem is that this is night pain, and it's relieved by aspirin. It's not growing pain, it's very focal. And if the aspirin doesn't quite work, you can ablate, you can pass a needle and probe in and destroy this. So here you can see in cross-section, this is the normal cortex. Here's the normal medulla, which is filled with bone marrow. Here's another fluid-filled space. That's the nidus. That's where the cells are that are making abnormal bone. This is just a shadow sort of cast by the needle where the X-rays are blocked from reaching if they're going this way. That's not really in the patient. And you don't need to fry all of the bone. You just need to fry the cells in this little nidus. Microwaves you're probably familiar with. Radio frequency ablation is not the same as radio waves. Remember, radio waves sort of just pass through buildings, and you can play your radio when you're indoors, and no one gets hurt by that. It's radio frequency electrical current, so a high frequency alternating current. It's a lot like the diathermy that surgeons will use to stop bleeding, but just remember it's electrical current. It's not radio waves. Okay. So now we're going to take a little bit of an attack, and just imagine you're a general surgery SHO on call, or you're in A&E. You're not really thinking about fractures and biomechanics like me all day long, or X-rays for that matter. But let's say you're seeing Doreen, a 75-year-old lady. She's not very active, but she keeps out of the hospital and lives alone. She's got COPD and hypertension. She presents with central abdo pain, vomiting, and constipation. The pain started in her back a month ago. She was taking lots of codeine. Her bloods are fine. Her epigastrium is a bit tender, but not peritonitic. And on PI, you find her loaded with hard stool. So if you've got sort of a general surgeon's thinking cap on, you might be very worried about this pain in the back. And you might wonder if this is dissection or pancreatitis, or some sort of flaring condition, sort of chronic pancreatitis that's better and worse and better and worse. And you can obviously have normal amylase in such a condition. But that's not what's going on. So yeah, let's say you get a CT, marked fecal distension of the large bowel and rectum. Well, you knew that from the PR, and that's probably what's causing her pain today. But radiologists are very good at finding more problems for you. More problems than the patient or referring clinician thinks they have. And in this case, you might pick up some vertebral wedge fractures. And what would you do in this case? How do you treat acute and old vertebral fractures? They don't often need surgery if it's just the anterior element. This is very different from burst fractures involving the whole ring, which are unstable. Let's just go back a minute. So this patient's got COPD. They're probably taking a lot of steroids. Pain started in her back a month ago. And then she's been taking codeine. So the codeine's been causing her constipation. The pain in the back has been causing the codeine, or causing her to take it. And that's what we really need to treat. We don't need to think, constipation's very easy to treat, or you might change her medication. But the root cause here was the vertebral fractures. And this is a CT in the sagittal plane. So the front of the patient is on the left of my screen here. Back is on the right. These are the vertebral bodies. Then the lamina and pedicle come in front and behind of the screen. This is the canal, the spinal cord sits. And if you look at the heights of the vertebral body, it's the front which is sort of wedged down due to chronic weakening of the bone. And the backs are fine. There's no spikes of bone that's shooting back into the spinal canal. So interventional radiology has a treatment for this. These are not fractures that would normally get an operation. You would treat someone if there was a traumatic fracture affecting the front and back of the spine of that ring, or multi-level instability. And in those cases, it's a bit beyond the scope of this talk, but sometimes the patient wears a brace for a long time. Sometimes they have metal work put in by the spinal surgeon. Okay. This procedure that I'm about to tell you about, vertebroplasty, doesn't stabilize the spinal column. It won't prevent damage to the spinal cord. It does stabilize the front of a single vertebrae, and the main indication is to prevent pain and get them mobilizing again. Okay? So what you can do is drill in, and you go in this sort of diagonal course through the pedicle. You don't go through the foramina. You don't go straight in the midline from the back and through the spinal cord, obviously. And you put in bone cement, and as well as just securing the bone fragments, this also creates a lot of heat as it sets. And that heat might kill off some of the nerves and sort of be a local pain-killing procedure. If you combine that with a high-pressure balloon to push the vertebra back up to height, you make a cavity and you fill that with cement. That's called a kyphoplasty. So plasty is molding, and kypho is what you're treating. You're treating kyphosis, where the front of the vertebrae loses height, and very commonly in the elderly, they become kyphotic and stoop over and short. The main indication, as I said, is pain. This isn't something that will suit everyone. So there have been a lot of trials to find out who is this for, who does this help, who gets the most benefit. And a few of the early ones showed huge benefit. And then some proper randomized control trials, including sham surgery trials where people had sort of the needle put in and a bit of local anesthetic injected, and then they'd crack and mix the cement anyway, so it smelled very funny in the IR suite, comparing that to the normal procedure where you inject the cement. In those cases, the results were a bit more modest. If you read between the lines of all of these studies, you find the ones where patients don't see much benefit is where you wait a while after their initial fracture, or when they come in and they're sort of found incidentally to have a collapse fracture. In those cases, you don't see much more benefit compared to simple analgesia. Where you do see benefit is in the first 6 weeks. So when someone has a very sudden onset of pain after a minor trauma, they come to A&E, they have an X-ray, they have an MRI to really check out the anatomy, check there's no loose fragments you're going to push back into the spinal cord with your cement. And then a short trial of analgesia, people who don't get all the benefit from the codeine in maybe the first week or 2 or 3. Those are the ones who are really going to benefit from vertebroplasty. But it's not widely done, and certainly it's something we should be restrained with because there are a lot of complications. So here's a fluoro image where the needle's coming in, the spine is sort of turned diagonally here, the needle's coming in diagonally through the pedicle. The cement's going into the bone, and it's leaking all over. It's maybe going to the disc space or into the nerve foramina, which would be a nightmare. You'd be calling the surgeon to say, come in and clean this cement out that I've put into the patient's L2 foramina before they get a radiculopathy. So you can do some harm with this procedure. If you have cement that leaks out and it just sits laterally or in front of the spine, there's no harm done. But it's when it impinges on the nerves or spinal cord, that's when you see real complications. And remember, the collapse fractures, that group specifically, these are ones where you don't get any neurology. You aren't expecting a retropulse fragment. You want to be very careful before you think about going in and causing a problem like that. And on the right here, we've just got a patient who has had sort of every level of their thoracolumbar spine, this huge segment treated. You might do this for someone with a huge amount of osteoporotic fractures. You can treat lytic lesions as well for pain relief, not for curative intent. There is some evidence that if you put cement in at one level, somehow that weakens the bone above and below it. So if you put cement in T11, then T10 and T12 are going to get a bit weaker, and you might come in with a wedge fracture then, and then you're sort of in this snowball situation where you're putting in more and more cement. I don't know if that's what happened in this case, but to me, this looks a bit extreme, like there's a lot of levels treated. More important than vertebroplasty, and something which will be your role as a junior doctor, or if you somehow don't choose the amazing specialty of IR, is the follow-up and treatment of vertebral fractures. I wanted to end on this because this is the most important thing I could say to you. So you need to think about falls prevention. Why is your patient falling? Do they have visual problems, balance problems? Are they on too many sedating meds? You want to think about your comprehensive geriatric assessment, whether that's in hospital or in the community. You want to do a bone assessment. You don't have to do these if your patient has a confirmed fragility fracture. So those are where patients fall from standing height and have a fracture. And that's most of the caseload. Most of the people who fall and break their distal radius do so just by tripping on the curb. Most of the people who fall and break their hip do so when they fall on the pavement. Unless you work in major trauma, you are meeting most people with fragility fractures, which you need to recognize. There's something called the FRAX score developed by the University of Sheffield, where you think about the patient's age and weight, steroid use, and family history, and that calculates for you the risk of further bone fractures over the next 10 years. If they don't present with a fragility fracture, you can do a bone density study, a DEXA scan. That's a little advanced, but basically it uses two frequencies of X-ray, one which is absorbed by the bones, one which isn't. So you can subtract the soft tissue and get just a picture of the bone. Kind of like when you've got 3D glasses and one eye is seeing red and one eye is seeing blue. And if you look through one eye, you see just one set of pictures. That's what you do. You take away the soft tissue, have a look at the bone, see how dense it is. Exercise, just as good as all the drug treatments for preventing fractures and strengthening the bones as well. But the cherry on the top of this slide and the whole talk actually is bisphosphonates. So among a range of bone protecting medication like PTH derivatives and strontium and hormones, bisphosphonates are very safe if you use them correctly, if you follow up your patient, if you give them a drug holiday after 5 or 10 years, if you stop them from getting esophagitis or you don't take it with food, you lie down straight after. These are really amazing medications. And the reason I like them is because they prevent fractures in the future. And if we started everyone on bisphosphonates, there'd be a lot less x-rays to report, a lot less procedures to do, a lot less wait for MRIs and wait for operation. And it might be a bit dramatic, but I've heard it described as like a TIA, like a transient ischemic attack for a hip fracture. If you have a TIA, you're sort of whisked into a clinic and started on aspirin. If you have a distal radius fracture, whose job is this anyway? Is it the A&E doctor, the orthopods, the GP? Sometimes it can slip through the cracks. And in some hospitals, in some part of the countries, there's a special service, not orthopods, but sometimes rheumatology or orthogeriatric specialist nurses who see all these patients. They're picked up sort of electronically, not immediately when they're in great pain or post-op, but a little down the line, they run through the bone health assessment. They think about drug treatments. And this sort of thing is all of our jobs, well, maybe not interventional radiology, of course. Everyone else can think really hard about this because it stops the patient coming back in 6 months with a hip fracture. And I've talked mostly about the x-rays and finding the fractures, but hip fracture is a condition for which the patients presenting with hip fracture, 50% will be dead in 6 months. Now, that's not due to the bone itself. That's not due to the operation. Sometimes it's due to the post-operative delirium, but very often it's because the patient is so frail, and you have to be rather frail to have that sort of fragility fracture. However, if we get this side of things right, picking up people with vertebral fractures or other fragility fractures, starting them on holistic treatment, exercise, fall prevention, bisphosphonates, you really can make an impact. And that is just as important as how to read a hip x-ray. So I thought I'd finish on that. At the end here, I just thought I'd list a few resources, a few orthopedic and radiology sites, which are very useful. Radiopedia is where I've got most of the images for this talk. Radiology Masterclass also takes you through the basics of X-ray interpretation. This website is for your fracture risk scoring from the University of Sheffield. Over here is one of the best textbooks for plain film X-ray. So on that note, going to take any questions.
What are the main and absolute contraindications to an embolization procedure? And is it only an elective procedure or also possible as an emergency?
Emergency bleeding after a knee operation. Well, that's if someone sort of sliced through the popliteal artery, and in that case, it's vascular surgery. Maybe it's a stent graft. You aren't embolizing, you aren't releasing particles. The post-op bleeding I was talking about is more of a trickle than a flood. It's someone who has hematoma that sort of never settles, and skin is always sort of leaking and oozing, and it's that sort of hematoma you're treating. Yes, IRs do treat emergency traumatic hemorrhage. You're quite right. The contraindications in the sort of elective setting, it's not so much contraindication. It's, anywhere you'd struggle to access these vessels, someone with a lot of atherosclerosis or calcium, or when you think you aren't going to make a huge amount of difference. If someone's problems aren't just due to the inflammation and synovitis, but if they also have problems due to the alignment of the knee, tearing of their menisci, problems with the ligaments, the embolization isn't going to fix all of those components.
Let's move on to the next question, which is regarding femoral fractures. So, avascular necrosis of the femoral head contemplated as complication of a femoral embolization procedure. So, okay, did you say, going on to femoral embolization then? Whether necrosis is a problem with?
I believe so. The cases of anyone embolizing around there. The blood supply of the femoral head is very tenuous, so you can get AVN as a complication of just sort of repeated microtrauma, hematological conditions where you've got small blood clots like sickle cell anemia, radiation. Yeah, I think you're right there. That's probably why I've never heard of or thought of embolizing there. So we've got shoulder and elbow, which are good, knee and ankle, and the plantar fascia, which is good. Yeah, I think embolizing around the hip would probably be a bad idea for that reason. There are some temporary embolizing agents where you have sort of a foam or thrombin-rich mesh which sort of dissolves away. And those are things you use for bleeding when you don't want to sort of completely block someone's celiac trunk. You just want it to stop for a bit. Yeah, maybe you could use that for, preoperative tumor embolization. But most of the time where you've got cancer, you have a lot of large vessels which grow. So you wouldn't really be accessing the circumflex ring. There'd be new vessels which the tumor would grow that you'd try to block off. But you wouldn't embolize to treat femoral osteoarthritis, which is, I think, what you're suggesting.
With regards to vertebroplasty and kyphoplasty, are the healing times afterwards equal?
Yeah, it's literature. Cases that were reported, they said sort of people jumped off the X-ray table and sort of danced out of hospital, and they were sort of instantly healed by the cement fixing everything. And it's the same with kyphoplasty. Now we see a bit less benefit. Patients are still a bit sore because they've got cement in and they've got some holes stuck in their back for these sort of access needles. But the idea is that you instantly stabilize everything and there's no real healing time. It's, if you're an orthopod, it's like when you place an intramedullary nail and you offer immediate fixation and the patient can immediately weight bear. The bone around the cement, or around the nail in that case, that there will be an ongoing healing process. The patients where you do vertebroplasty, you aren't worried about stability. You've already selected all of those to wear a brace or see a spinal surgeon. But the pain relief is meant to be almost instantaneous.